We're presenting here data on the long-term follow-up of the OPTIMUM Muknine trial. This is one of the first trials that offered stratified treatment for patients with high-risk myeloma. We still use the title ultra-high-risk myeloma in the title, but there will be an updated risk classification paper out next year by the International Myeloma Working Group. And actually, this trial was truly designed for those patients that are going to be called high-risk moving forward. So patients that had 2 or more genetic high-risk aberrations co-occurring and or genetic gene expression high risk, or they had plasma cell leukemia. So these patients received treatment that differed from standard of care and even from the new quadruplet regimens, in that patients received 18 months of DARA VRD consolidation therapy, so significantly more than you would get in any of the current standard of care regimens. And we compared the outcome against an external comparator group that received KCRD, a transplant, and lenalidomide, or CRD, a transplant, and lenalidomide. So with the long-term outcome now, we see very, very encouraging results. We see that 61% of patients are still progression-free at 5 years. The median progression-free survival has not been reached, and that is compared to only 23% of patients still staying in a remission in the standard of care arm, and that's actually true regardless of the induction regimen, so including KRD type induction regimen. So that was confirming what we had thought when we designed the trial, that the consolidation therapy is actually one of the most important elements to keep up the intensity for patients with high-risk disease. But thanks to the really comprehensive genetic diagnostics and gene expression diagnostics, we could also look at subgroups within that group. So we do see, for example, that patients that have triple hit disease, so 3 high-risk genetic lesions, unfortunately still have quite poor progression-free survival. And they could be, for example, a prime target group for future high-risk trials. We also see that there is really need to test for both genetic and gene expression profiling, because it tells us, in the end, 3 different groups. It tells us a group that only has gene expression high risk, one that has both genetic and gene expression high risk, and one that has only genetic high risk disease. Now, what we could see in the results is those with only genetic high risk disease, so 2 genetic high risk lesions, did phenomenally well in this trial. All 3 groups benefited, all 3 groups had not reached their median progression-free survival, but the ones with only double hit disease without gene expression, nearly everyone stayed in a remission for 5 years. So I think we're really getting a big step closer with this trial to personalizing care and to recommending what a good diagnostic workup should be for patients, so that we can tailor treatment, especially in the long run, in consolidation and maintenance, to the individual need of the tumor.